ultrasound evaluation for doing a surgical planning. Everybody know Ahmed. Ahmed don't need presentation. Ahmed is working very hard, like 10 years ago on PAS, and in the last year, in the last 2 years, has a lot of paper, very interesting paper, concept changes, changing paper, and we are very, very pleased to have Ahmed with us today. Ahmed, thank you so much. We hope to you discuss a lot. Everybody that connect today, we will have the opportunity to discuss. If you want to open your mic at the end, that is possible. If you prefer to put in the chat box, I will be ready to read the chat box and transmit the message to Ahmed. So thank you, Ahmed. Please, the floor is yours.
Thank you, Alvaro, so much for this presentation. And I changed a little bit the title from surgical planning to how to do the preoperative ultrasound assessment.
I'm sorry, Ahmed, we are recording, Luisa, or not? Let me be sure.
Yes, we are recording.
Okay, I'm sorry. Go ahead, Ahmed, sorry.
So this is very important because surgical planning by ultrasound, when we talk to Alvaro a lot, needs a lot of training, but doing an ultrasound as a tool for preparing tool for surgical topography is another issue, and it needs less training, and it's very helpful. So I will start with some history. Just a second.
Hablando desde Egipto. Surgical Topography Project.
Eduardo, please mute your mic.
Okay, I need to share the screen again because I don't know what happened. Surgical Topography Project, this one. Okay. Okay, just a second. This is what I hate. So we will do some history, and this will be very helpful in this surgical topography project. In 2013, to 12 years ago, starting doing this on a regular basis, we have the following challenges at that time. We don't have a proper diagnosis, we don't have a clear surgical plan, and also at that time we had a lack of experience 12 years ago because it was for us not that much cases before that time. So what we've working over the past years from 2013 till 2020, before I met Alvaro in 2022, is that we try to build up our team, we try to build up our surgical experience, we try to build up our ultrasound experience in how we can do a proper assessment by ultrasound and doing a proper surgery for the ladies. And these are the plan of surgeries, the provisional plan of surgeries that anyone needs to know. But the question is, as you always know, when to choose one. So the choice of the surgical plan will depend on the patient's difficulty, the surgeon experience, and the availability of the resources. But the problem is, and this is very important, how to assess the patient's difficulty. I know it's very much harder to how to assess the surgeon experience. And the thing which is very objective is the resources, because if you have it or you don't have it. But the patient's difficulty remains a very good question of how to assess the patient's difficulty, because the problem is any time when something went wrong, they all rely on the patient's difficulty, not that something happened in the surgery. So before I met Alvaro, I was convinced that the ultrasound can perform about 40% of the job in proper surgical planning, and then with the proper surgical technique, you can choose the proper surgical plan and then you go for the procedure. And then Alvaro in 2022, when we first met, he told me about the idea with Jose and Alvaro about the surgical topography. And by that time, as in something new, in the beginning, there is some resistance from my side because I had a very good system working in my hospital. We had a very good results. So why to change? This was the question. And then Alvaro told me something which is very important, that yes, you're doing great. You're training 6 people, but there is a lot of patients in a lot of countries not having the same center of excellence, not having the same numbers of patients. So they're not that having a good opportunity for training, and need to help these people. So by that time, Alvaro put a very important thing about how to help people to perform the surgery in a proper way, having a better outcome. And at the same time, these people in some centers, either they don't have this big number or they don't have a very high resources. So I asked Alvaro some questions about the surgical topography. And then when we discuss it, roughly me and him in a very deep way, we realized that yes, sometimes when you open the lady, sometimes you can be misled by the intraoperative image or by the intraoperative picture that you see with your eyes. So we need just to add some ultrasound criteria, which is very simple and basic, to help and to guide the surgeon during doing the surgical topography to make it a little bit more safe. Because if people do the surgical topography and then they have a problem in the first or second patient, they will not do it. So how to make it more safe when you open the abdomen? So to make it safe, Alvaro, we worked together about this ultrasound criteria, how to do the scan, and I think that he gave a lot of presentations how to do the scan and the images. And then when we share the images of people, sometimes people, they don't understand why they do the ultrasound before doing the surgical topography. So the images sometimes lack what we exactly need to know about this patient before doing the surgical topography. So the idea and the presentation in the second part is about how this ultrasound can complement and helping doing the surgical topography. So what we need to ask ourselves and what criteria that we'll see by ultrasound is the following. Number one is the placenta localization. And with placenta localization, when we send images or videos, and I show you a lot of this in the presentation, we need to know that we need to have the cervix in the image. The midline of the lady is different than the midline of the uterus. So the landmark is the cervix. So in the image, we need to have the cervix. And when we have the cervix, we need to answer the following question. Is this a mainly anterior wall placenta, or this placenta is anterior and posterior, which means pelvic placenta? Is this placenta has a lateral extension? And that's why Alvaro, in his proposal, you do a mid-sagittal scan, either take a short clip or an image with the cervix in the middle, or when you do a transverse with the probe and move from side to side to see which side the placenta is. So this image is very important because when you do the surgical topography, the surgical topography is based that going into the spaces, because I know all of you, when you're involved in the projects, you know that. So what if I have the placenta mainly on the left side? So while doing my surgical topography, I will start the section on the right side, away from the placenta. So this will be the right to do is to go from the contralateral side of where the placenta is mainly on the other side. And this will help us to enter the space, which is be less vascular, the side which is contralateral to the placenta. So it's very important to understand. The second thing is when I have an anterior wall placenta, I can go for more bladder dissection. And even if the bladder is a little bit stuck, I'm not afraid of doing more bladder dissection rather than the placenta is completely impacted in the pelvis. So if bleeding will start, sometimes people will be afraid they will not control the bleeding. So anterior wall placenta is different than the placenta is an anterior and posterior. It's different than the placenta is on the lateral side. And when I see the placenta on the lateral side, which means the left, then I mean that you need to start the topography on the right side. So it's just few tips that will help us and then to relay the ultrasound to the surgical topography. The second thing is the vascularity across the bladder. I'm not talking, and we'll see a lot of videos in the next 5 minutes about the Doppler. Don't care about it. But we must understand that when we have few vessels between the placenta and the bladder, which means that the dissection will be much easier and to mean that doing Palacio maneuver can be done. But if you have a multiple bizarre shaped vessels between the placenta and the bladder that the myometrium is not recognized, then here I need to ask myself when I'm doing the surgical topography whether a blunt dissection using the Palacio maneuver will be helpful, or I need to go for a sharp dissection to avoid bleeding while doing the surgical topography. And again, I will stick to the first rule, where to start the topography, from the right or the left, based on the placenta localization. And again, the subplacental hypervascularity and the cervical hypervascularity, both of them are an indicative of when I do the surgical topography and when I open the spaces, I will dissect the bladder, okay? So this is what I'm thinking of. Is this a good candidate to do one-step conservative surgery, or this is a candidate to do an hysterectomy? And this will be based at this exact moment if I do the proper topography and if I do the proper surgical dissection and I've exposed the disease segment in the cervix. This will help us, according to my experience, whether to do the step is an hysterectomy, whether subtotal or total, or I do for transparenchyma surgery. And this is where you see the lateral side and vascularity. And the most important thing, which is the key of the success and the key of what I think that you can help you and you're confident when doing the surgical topography, is the myometrium in the lower segment. And here is very important when you see, this is one of cases that you have the cervix here, and this is the external os, this is the internal os, and this is the lower segment. As you can see, sometimes people, they say that this placenta is at the level of the external os, which means that the placenta is invading the cervix. No. The placenta by its weight is bulging anteriorly to the bladder, which makes it in the ultrasound appearing that as if the level of the external os, sorry. But if you look at this, this is the same patient. Here is the placenta. And because there is a failure of a defect, there is a big defect that repair will not be that easy. So we decided to do an hysterectomy for her. Here is the cervix. And if you leave my fingers by its weight, and this is the image that you saw in the ultrasound, the placenta by its weight is bulging anteriorly and the cervix is just beneath it. And here, when I see a lot of examples in the next few minutes about the lower myometrium, the myometrium near the cervix, because if you want to do a repair and you're going to do proper surgical topography and you have a myometrium and healthy myometrium near the cervix, you will continue the section of the bladder till you reach this myometrium, and then if you are either going to do manual separation of the placenta, do focal resection of the myometrium, you need to have a myometrium in the cervix where you're going to do a proper repair for this ladies. So here is a few examples of when you open the abdomen. These are 4 cases. When you open the abdomen, this is the first one. So here is a bulge, and here is the bladder. And as you can see, there is a thin adhesions between the bladder and this bulging myometrium with the placenta below it. So here we can do a Palacio maneuver because this adhesion is not that firm. And when you do the dissection using the Palacio maneuver, you can find the placenta and you can find a good myometrium down there near the cervix. And then when you reach this level and you dissect laterally, dissect anteriorly, dissect everything, then you can go for what's called one-step conservative surgery. And here is the ultrasound of this. You can find the cervix, you can find the placenta. Here is the myometrium is thinned out, but there is a myometrium between the placenta and the bladder where the repair will happen. And if you go for the transvaginal scan, you will find a good myometrium near the cervix where the repair can be done. And you find the bladder wall not vacuolated, not enlarged. There is not hypervascularity in the bladder, and this is the uterus when you close it. Another image. So you have this image and you open the abdomen and you want to do proper surgical topography. So if by a scan, I know that this placenta is a complete centralis, here is the cervix, and I know that there is hypervascularity, and when I go for the transvaginal scan, as you can see, there is a lot of vessels near the cervix. And when you have the color Doppler, and near the cervix, you have hypervascularity, and this hypervascularity are more toward the right side of the patient. So my choice for such a lady is I will try to go for proper bladder dissection, opening the left side first where the less vascular near the cervix, because the problem is in the vascularity and adhesions near the cervical region when I do the surgical topography, when I open the planes. So my surgical idea, I will start with the left side, I will dissect the bladder, and because there is not enough myometrium near the cervix, I will go for hysterectomy for such a lady from the beginning, and this is safer for the lady because there is no proper or there is no sufficient myometrium for the repair. Coming to the third one, you have here the bladder, you have the placenta bulging beneath it, and here because also there is a very thin filmy adhesion between the bladder and the placenta, you can go with your fingers the palaceus between both ends, and then you can see the posterior and feel the posterior wall of the bladder, and then you can do the palaceus maneuver, dissect the bladder, and then go for doing a one-step conservative surgery. But if you can see also the vascularity is low, and as you can see, there is good myometrium near the cervix where you can do the proper repair. Coming to the last one, which is very important, when you do the surgical topography, and this is one of the things that I talk with Alvaro with, sometimes it's impossible to dissect the bladder. Impossible to dissect the bladder at the beginning. Sometimes, yes, it's not common. The common that you can be able to dissect the bladder, and by time you'll dissect more and more and more, but sometimes I'm telling you it's impossible. Yes, very rare, but sometimes. So in such a lady, you open the abdomen, we try to dissect the bladder, but it wasn't impossible. But if you looked at the images of the scan before doing this procedure, you'll find that there is high vascularity, thinning of the myometrium, the placenta is deep inside the pelvis, there is multiple vessels, and when you go lateral, there is a herniation of the placenta from the lateral wall, and when we open the abdomen, the bladder is so stuck, but we decided that we go for a hysterectomy from the start, getting the baby out from a separate incision. As you can see, the placenta was herniating from the posterolateral aspect. So sometimes it will be very hard to do the surgical topography, not common in a rare situation, but if you know with the ultrasound that this lady is a candidate for hysterectomy and you start to do the surgical topography and you will not be able to dissect, you need to get the baby out from a separate stab and start with the hysterectomy. This is very important because if you go further, say that I want to explore the placenta to the lower edge of the placenta and then going to not proper planes, doing rough surgical manipulations, you may start bleeding before doing anything, and then you will say, I will stop this because the surgical topography didn't help me. No, it will help you a lot. But in a rare situation, sometimes it's very extremely difficult to dissect this bladder. So if you do proper scan and you have a proper like what you feel, imagination of what you are doing in the procedure, it will help you a lot. So Alvaro, I'm very sorry, but I want participation from you and from Palacios. So if you open the abdomen doing a scan for such a lady, what do you think? And if anyone wants to participate, because we need to do an open discussions. And this is very interesting because this I did it 2 days ago. If you open the abdomen,
you're asking about how.
What do you think? So this
Okay,
lady didn't do a scan, come to the emergency, you open it and you found this. What do you think of this?
So no scan, emergency surgery, and I found this. So I can tell you nothing because I need to open the spaces. I need to open lateral and do the bladder flap. But there are vessels. The only thing that I can tell you is don't go for that segment, vascularized segment. Please don't open as usual. It's not a simple C-section.
But your idea is that we do the surgical topography. So this lady will be saved by one of two options. If you don't have a scan, this lady will be saved by doing the surgical topography. If you have a scan, this will help you in doing the surgical topography. I will show you the scan first. So this is the scan of the lady. Okay? There is no placenta at the bladder side. The placenta is posterior wall. This is the cervical canal. This is just dehiscence. And there is a good myometrium near the cervix. So it was very deceiving if you don't do a scan for this lady. The placenta is posterior. The placenta is not anterior wall. The placenta is posterior. So supposedly you didn't do a scan for such a lady, okay? And you open it in the emergency. The adhesion is not that extensive, and you can do a proper opening of the spaces on both sides, and I will show you. Okay, so here is before doing anything. Okay, you find it. There is some vessels. The placenta is more towards the left side, and this is why there is some vessels on the left side, because it's posterolateral to the left. And the right side is, yes, there is some vessels, but it's clear. So if you do proper surgical topography, opening the spaces on both sides, start dissecting the bladder, then you will have this image. Now you will realize that there is no placenta, that this is just adhesions, and you will realize that the placenta lying posterolateral and it's not on your way, and you realize that you have a proper myometrium near the cervix, and then you will change your surgical plan if you do proper surgical topography, if the lady didn't do a scan. And then you will do proper repair. So it's very deceiving. And the problem is, if you go for such a lady and think on the spot that this is a placenta previa, anterior wall, and this is a high vascularity, because the dehiscence will not make you see that clear. So if you have standardized protocol that I will open the spaces, I will dissect the bladder, and then I will reach a good healthy myometrium. At this exact moment, I will go for an incision at the upper edge of this defect, and then I will get the baby out, and then I will get the uterus out, and they will see where the placenta is, and then I will see how the placenta will separate, and then I will remove this defective part, and then I will do a proper repair. Then you did a great job. So this lady can be saved without scan. Yes,
Ahmed,
Albar.
let me say something, because you and Eric and Karin published about complex C-section 2 years ago, and everybody now is talking about complex C-section, and complex C-section is about topography also. It's about restoring the anatomy. It's about the same concept that Dr. Palacios is studying 20 years ago. So what happened if I open this defective area and then I try to close a big, thick upper border of the hysterotomy with a very thin lower border? Most of our colleagues close with the bladder at the end because they don't dissect the bladder. So the only way is to include some part of the bladder wall to have a proper closure. So these concepts about topography are not only for PAS. That is a very good example of how to apply topography and dissection that we, of course, we talk a lot about this on PAS, but it's very useful for complex dissection, not previa or previa without accreta.
I totally agree. It's all about when you have a problem in the lower part near the cervix. This surgical topography will help you in three things. Number one, you will open the proper planes. Number two, you will dissect the bladder exposing the Z segment. And number three, you will have time to see what you will do next. Because the problem is doing a hectic surgery will lead to rough manipulations, and rough manipulations will lead to bleeding, and bleeding will lead to more hectic surgery, and this will lead to more blood loss and more injuries. So one of our problems is that when people send Albaro images and it's not clear. So when you have this image, for me, if Albaro send me this image, it's not clear for me what will do for the patients. Why? Because the cervix is not clear for me. I don't know whether the extent of the placenta, if this placenta ends in the lower segment or this placenta is an anterior wall reaching the fundus. So sometimes people send Alparo an image like this and then asking him what to do for the patient. I don't know. And this is a big problem because they want to have a surgical plan from a certain image. So this is impossible. When we talk about this, when Albaro in the past few months talk about, you need to have a series of video clips and static images, both abdominal and vaginal. So this becomes a little bit more clear. We have here a video showing from upwards. These are dilated spaces with blood vessels. Here is the cervix. When we go with the transvaginal, we don't need the color Doppler for such ladies. As you can see, this is the cervix, and this is vessels in the anterior lip of the cervix and vessels in the lower part of the uterine segment. It's highly vascular, and it's the vessels near the cervix, and the myometrium is lost. There is no proper myometrium, so the decision for such lady is doing a hysterectomy from the start. So this is when you open the lady, and this is one of the key that Albar was talking about when telling the surgical topography, and this is very important. You'll open the spaces in the round both sides, and you will start to do the dissection of the bladder. Sometimes it's impossible to do the Palacio maneuver. Impossible, I mean impossible. So you need to have proper fine dissection, not blunt dissection. And sometimes it's impossible to continue the bladder dissection till the end. So sometimes you just start the bladder dissection, opening the planes on lateral sides and the posterior wall of the bladder demarcate, and then get the baby out, and then continue such a thing. And here you can see part of the placenta with a very thin myometrium cracked, and the bladder is still extremely adherent to the myometrium in the midline. Yes, in the both sides were freed, but the midline is so stuck that we get the baby out first because this capsule cracked and you don't want the baby to be compromised. And then we continue the dissection after getting the baby out. And then for such lady with this high vascularity near the cervix, we go for a total hysterectomy for such lady, okay, after proper dissection of the bladder below the cervix. So sometimes we go for total, sometimes we go for subtotal. It all depends on the patients and all depends on what you see in the ultrasound, and you confirm intraoperatively. And this is the image. As you can see, the cervix was displaced posteriorly. So let's go for such a lady. So on this lady, here is a static image. The cervix is not clear, but the cervix, part of the cervix appeared, and the placenta appeared to be adjacent to the bladder. Here, when you have a proper cervix, the placenta is bulging to the bladder because there is no wall between the placenta and the bladder. It's very thin fibrous capsule. And here, when you can see, when we do a proper abdominal scan, we see that the placenta we go a little bit to the left and then return to the midline. The placenta is more to the left. And here we need to see that this placenta is more to the left and the myometrium is more deficient to the left. And when you go for the plane that Albar wants to tell you about, when you go for the TS, as you can see, the placenta on the bladder wall, there is a big defect. So, and this defect continues still down near the cervix. So here we have a big defect, anteroposterior and lateral. So there is a big defect in the lower segment. So is this lady good candidate for doing transphalangeal surgery or not? Before doing the surgical topography, we need to do a transvaginal scan. So here we can see a few things. Number one, we have a myometrium near the cervix in the lower segment. Number two, the vascularity is not so high. The bladder wall is not vacuolated with vessels. So we decided that you go for a surgical topography and then start to do what we do next. So here when we open the abdomen, what do you think, Alvaro? Can't tell.
I think let's ask Dr. Jose. What do you think?
Okay.
You are mute, Dr. Jose.
Okay. At first, this is I need to open the spaces because most parts of the uterine segment is covered. It is impossible to know what is below of this. It's the same in all the cases. Sometimes the people say bladder is quite impossible to move. Obviously, in some cases it is, but this is only a first view. Do you have not? It is impossible to make a decision with this picture no decision. First, you need to open the spaces, then to try to dissect the bladder, and then when you perform the bladder flap, to see, to evaluate it, and then to see, okay, this is my next step.
Alvaro.
Totally agree with Dr. Jose Palacios, and it is very important because most of the hospital, like mine, I don't do the ultrasound. My colleagues do the ultrasound. Of course, we have a group, so I go to the ultrasound room and I be there. But most of the hospital, one person do the ultrasound and other person do the surgery. And most of the time, these people don't like each other. So, and they are waiting. That is crazy, but in some hospital, the colleagues are waiting to the other fails. So if I see this, I see, oh no, the MFM specialist, nothing. And this lady has nothing because it's quite normal laparotomy for a placenta previa. So this is even heavy bleeding can occur if a surgeon got transplacental in this lady before doing the surgical staging. So I agree, we need to expose the lower uterine segment.
Exactly. So thank you so much for your answers, because the problem is for such an image that I saw when I just saw these images, when I make people see these images, I had two different opinions. One said that the placenta is bulging and I will go for an hysterectomy away from the placenta and do hysterectomy. And the other will say this is normal and I go for a transplacental incision and get the baby out and then get the placenta out and see what's going on. So for the same lady, we have two ends of the spectrum from people, and both are not right because they don't understand the diagnosis. We don't still this exact moment, we don't know where the placenta is, where is the extent of the placenta. But with the scan, we know few things. That the vascularity is low. We have a myometrium not that long, but we have a myometrium in the cervix. So it's better to confirm it by doing the surgical topography. But again, sometimes it's not feasible to go for the Palacio maneuver to put your two fingers between the bladder. Sometimes it's impossible because sometimes the bladder is stuck on the lateral sides that it's very hard to go for with your fingers without cracking the capsule, because we need to understand that there is a big defect in the uterine wall and it's very hard. And this here is the defect after doing proper dissection. But from the scan, we know this defect is an anteroposterior and lateral defect. So this we have a big defect where the placenta
we need to stop here. We need to stop because this is the same lady that you show in the ultrasound.
Yes.
This is because the ultrasound had not so many lacunes, so it was like a simple dehiscence. But this is percreta in the old
No, this is simple
terminology.
Also.
No, I understand, but it is important to focus on this because after dissecting the bladder, this is so ugly, this is percreta, and this is bladder invasion in the old thinking, I mean, in the old terminology. So this is the dehiscence. At the end, who cares? Who cares what it is?
Exactly.
We need to solve surgically this problem, and let's solve that issue about dehiscence or percreta after surgery. So it's very important. We have a raised hand from Yalda after you comment on this.
Okay. Yes, Yalda.
Yalda, did you want to comment?
Yeah, sure. My question is, when we do this, and I try to copy all your models, but when we use intraoperative ultrasound, so this is a point before you dissected the bladder that I would ultrasound on the uterus. Is that part of my surgical staging? I'm going to always use it because it feels safe for me and I like it, but I don't know what that is from the system that you guys are trying to put forward. The ultrasound that I do in the operating room to see where is that? Tell me about that. I just want to know what that is and everything. Is there a role? I love it. I'm going to keep doing it.
Do you want to answer, Ahmed?
Let me for you, Alvar, not for me.
Yes. I in the past, I wrote this a lot of paper about this intraoperative ultrasound, but again, it's about concept because if I am trying to avoid the border of the placenta, I am thinking that all the placenta is compromised, and that is not right. You have like 30, 40 centimeters of placenta, but most of the cases you will have less than 8, less than 6 centimeters of dehiscence. So it's not important to avoid the placenta. It is if the only strategy you have is go transplacental. But you need to remember that you have the ward maneuver. So you can open the uterus and avoid to cut the placenta. You put your hand between the placenta and the uterus. So the only thing that you need to see is this picture that Ahmed is showing to us, the abnormal myometrium. If you see
But that's what
normal
I do for the
myometrium,
ultrasound. I don't use it to avoid the placenta. I use it to find myometrium.
okay, but you can use it. You can use it, but
Yes,
you
but if
you
you
will
can see in
dissect
the
the bladder.
images, there's no myometrium here.
Yeah, yeah.
And if you can see with the transverse, you still have a defect. It's not only anteroposterior, it's also lateral defect from above downwards. And then when you go for the transvaginal scan, we just focus on this very thin myometrium near the cervix, but above this wedge, there is no myometrium between the placenta and the bladder. So the idea of doing the intraoperative scan, it's not feasible for most of people. This number one. And number two, it will not add if you expose this segment surgically, and then you will see whether you have myometrium healthy near the cervix or not.
Exactly. It's useful if you have not the bladder flap. In this moment, maybe it's useful in this moment. But in all the cases, you need to do the bladder flap. So after doing the bladder flap, you will see directly the abnormal myometrium. So if you want to do it, it's okay, but really, and I agree. For example, here in Colombia, I am in the big hospital in Colombia, the bigger hospital in Colombia, and intraoperatively, I have only a low quality ultrasound machine. I cannot put the what is the name of the General Electric, the last generation big ultrasound machine. I cannot.
Yeah, E10.
Okay, that is, I cannot use it inside the operation room. So.
Yeah. Okay.
Okay.
No, this makes sense. This is helpful. Thank you.
Exactly. So again, opening the spaces, doing fine dissection of the bladder, because if in such a lady, if you put your fingers in the wrong plane, and this capsule will crack, the whole placenta will be inside the abdomen in 1 minute. The massive hemorrhage will start in less than 10 seconds. So this lady, one of the cases that you need to do a fine dissection of the bladder to reach a proper surgical plane to dissect the posterior of the bladder. And then what we did next is that we get the baby out from an incision at the upper edge of this defect. We got the uterine incision here. We get, as Alvaro say, we just put the placenta aside, get the baby out, and then we have the bladder downwards. We have the part of the uterus that is defective. What we need to do is that getting the placenta, the upper part of it, and then the lower part of the placenta, either it is accreta or not, we really don't care, but this is defective myometrium that we need to resect it to close properly the uterus. So what we need to do is that we identify where is the bladder, we identify the end of the placenta, we try not to have a lot of healthy myometrium removed with the placenta. So we demarcate where is the healthy myometrium is, and then we cut the defective myometrium with the placenta, and then we have the uterus with a myometrium near the cervix, and the uterus is closed after doing proper topography, doing proper dissection, opening the whole planes, dissecting and exposing, and this uterus and this image of the same lady at this image. But again, how we achieve from this image to that image by proper dissection, exposing the disease segment, dissecting the bladder, sometimes blunt, but most of the cases with sharp dissection to avoid injury of the very thin capsule surrounding the placenta, and then it's according to what you have and what you experience. Sometimes you see that you're not confident on doing repair and need to go for hysterectomy because the defective area is so big that you don't do the repair. It's according to your surgical experience at that exact moment. But in both, whether you're going to do a repair or going to do a hysterectomy, the patient's saved at the end. So the thing is, what I really want to say is that I did believe in the ultrasound as a tool for surgical planning for a lot of time. Till now I believe in, but it needs a lot and a lot and a lot of experience to say, I do the scan and then in 99.9% what I see in the scan, I will do exactly in the OR. This needs 10 years of experience doing it every week, and this is not feasible for most of the centers. What is feasible, what I think is really feasible, is that doing a scan, which is just placenta localization, where is the healthy myometrium in the cervix, where is the part of the defect in the uterine wall, where is the high part of the vascularity, where is the side where the placenta is mostly implanted, and then go for surgical staging. And then after surgical staging with this initial ultrasound scan, then do surgical staging. And then during the surgical staging, either you can dissect the bladder to expose this segment, blunt or sharp, or not be able to dissect the bladders that much, so we get the baby out from a separate incision and continue doing the surgical topography after getting the baby out. This is a safer option, and we need to explore it, and we need to do a large number of cases to see the feasibility and even to see the challenges and the problems that we will face it and how to fix it. Thank you so much, and I think we have a good discussion.
Ahmed, let me go back one slide, please. This is the same lady, to be clear. One back.
This is the same lady.
One.
The same lady.
Another back.
The
Another
same
one
lady.
with the bulging.
The same lady.
This one. So it's the
Yes.
same lady. We have a great question from Jorge Collantes from Peru. Jorge is doing PAS there several years ago, and he's asking in the chat box about a very good question that we have this question for all the cases. He's asking, how if I have the bladder flap complete, the bulging area isolated, but with a vascular cervix? How to be sure it's just the case that Egle sent to us yesterday? If you have a vascular cervix, go one slide ahead. The two slides. No. Ahead. The next one. Next one. That
Okay.
I think is the last before the reconstruction, because you already finished the dissection. This cervix, I guess, this cervix was highly vascular in the
Exactly.
ultrasound. Yes. So
and we took hemostatic sutures.
Yes, that is the important thing, because all these cases, I mean, the big bulging with big vessels, these vessels will come from below. So you will see these vessels in the ultrasound, and this will have a lot of color in Doppler color, but it will be not blood if you control this with hemostatic compressive suture in the lower segment. That is the reason Dr. Jose proposed to put 3 stitches in the midline and in both sides. So if you can expand this concept, he's asking how to be sure that after resect the bulging area, I will have not bleeding from the lower part.
No, I want to tell you something which will be much more simpler, because when I think about it, I think like most of the people, and this will help to save a lot of patients. If your surgical skills help you to dissect and expose the Z segment, then you will go for removal of the Z segment, and then sometimes you will have vascular bed from here. You will have one of 2 options. But if you really, with your bladder, moved it below the level of the Z segment, you'll have one of 2 options. Either you will do hemostatic suture to control the bleeding and close the uterus, or you're not confident, the hysterectomy will be easy, fast, no problem, no injuries. So it's not about I must do a transplant surgery. No, I must do the best to the patients with my experience. So if you can able to dissect it, expose it, resect it, and then see if you can able to control the vascular connections, close the uterus. If you're not able to control these vascular connections, put 2 clamps on the uterine artery near the cervix, because you dissect the bladder anteriorly, so there's no injuries, and then do hysterectomy for the lady.
Yes, and that is so important, because this is the reason Dr. Jose told me. Dr. Jose is teaching people 20 years ago, and some people don't follow the instruction. So some people watch the presentation and they say, I am a good surgeon. I can go from this presentation to apply in my operation room. So they don't do the bladder flap complete and they try to cut the abnormal area, but they don't secure the vessel. So they have heavy bleeding and the conclusion is this doesn't work. This is a lie. I abandon totally. I will not try this again. And they keep doing hysterectomy as the only option. So it is very important to expose the lower uterine segment to reach this level of dissection. This is, I think, you spoke everything until the vagina here, but sometimes it's not necessary. But if you reach this, you can do everything and you are totally sure. You can put a tourniquet in the lower part and you can work totally free of blood loss. So we need to understand where the blood comes from, and it's from the lower part, from the vagina. So you need to put stitches before doing the focal resection, or as you say, go to an hysterectomy. And that is a very second important point. This surgical staging is not for focal resection. This is for a comprehensive treatment. This is for avoid hysterectomy in placenta previa with false positive in the ultrasound or false positive in the MRI. In my hospital, 30% of the percreta cases in 2016 was really placenta previa with hypervascularization, nothing more. But these ladies lost their uterus without a reason.
So yeah, this is what I totally agree about, is that three main points, if we get it as a take-home message, will help us a lot in our practice. Number one, you can't say from an intraoperative, when you open the abdomen, what to do to the patients. You need to expose the disease segment. This is number one. Number two, to complete the surgical topography, you need to reach below the disease segment to see what's going on. And sometimes you will not be able to do it in one step before getting the baby out. Sometimes you can do it in two steps. Try to dissect the bladder as much as you can based on your experience, and stop if it is stuck for you, because you build up the experience by time, and then get the baby out, and then continue this bladder dissection before taking the decision whether you go for hysterectomy or for transplanting surgery. This is number two. Number three, what Alvaro said is that this is not this standardized protocol to help to guide you to your surgical plan, not just only to preserve the uterus. This is not made to do a transplanting surgery for all the ladies. This is made for helping you to do a proper surgical plan. Before I met Alvaro 2 years ago, I told him when the first time, Alvaro, I don't need this. I'm doing well. I'm doing my surgical plan by ultrasound. I'm doing a proper surgical technique. So I'm doing a great job. And then I realized that with less experienced people, this will help them to gain experience much more rapid than teaching them a technique. This will help them to build with their own technique and standardized approach to build up experience by their own. So it's very helpful. I'm telling you, when I resist this 2 years ago, but I'm telling you right now, it will be very helpful for people to help them to standardize the management and help us to decide what is the best surgical plan for the ladies.
I want to comment something, Ahmed, because we sometimes mention the word experience, and that is exposition to the disease. And some people feel bad about telling experience, but it's impossible to compare the experience from people like you or Rosie doing 3 cases per week as people like me doing 1 or 2 cases per month. So the experience in PAS is not being great surgeon or great gynecologist. It's trying to analyze each case and have a lot of exposition of these cases, go back, doing feedback, analyze our mistakes, recording our surgical procedure. So that is the kind of experience that we address in our talk. And a very important issue to reach this experience is to share the cases, because I am doing with you like 6 months ago, like you are teaching me each week when you send me the ultrasound, and Egles send me her ultrasound, and then she sent to us the surgical results. So I learn about her cases. So it's a very good way to gain experience in this kind of new concept. The second thing that I want to address is this: it is not easy. This is not easy, even for highly experienced surgeons in other kind of condition. So don't feel bad if it's difficult for you, because the responsibility to change the way in which you treat PAS is high. The worry about failing is real. I feel that worry some years ago. You will have opposition inside your hospital. You will have colleagues that are waiting to you to fail. So if you share in this safe environment, you will be not alone. You will have, I am sure that if somebody sends you picture, Ahmed, you will respond to them with surgical advices. So we are not alone in this process to improvement. If any of you have questions, when we plan this meeting today with Ahmed and with the group that are uploading data to our project, we think about sharing difficulties. If you have some difficulty with planning the surgery using the ultrasound, please, it will be great if you share with us. I don't know if somebody wants to talk. Egle, maybe you, Tulio, Pele, I don't know. Somebody want to, because it's not easy. If some of you say that it's easy, you are lying. So please, somebody is Pele, please go ahead. Pele from Greece, open your mic, Pele.
Can you hear me now? As
Yes.
I wrote in the chat, I'm impressed with the amount of bleeding you have with these stitches, with these colcuterine stitches. But when you saw a picture, Ahmed, when you had a cracked placenta, didn't that bleed?
Ahmed, Pele is impressed with the low volume of blood in your field during your surgery. And he is asking about the capsule cracking, how you handle the capsule cracking.
Okay, so the truth is, when you have a crack in the capsule, we've tried a lot of things. The problem is if you applied more traction on this capsule, if you apply, sometimes if you apply any instrument, the crack and the defect will increase in size because it's under tension and if you applied anything. So the problem when you have a crack in the capsule, we lose one hand because one of the people in the side, the OR, their whole role is to have a wet gauze and do compression on this crack for the rest of the procedure till we dissect the bladder. So we were losing one hand because someone will do a compression on this cracked capsule for the rest of the procedure and do nothing in the procedure except having a wet gauze, putting on this crack and doing compression on it till we do the bladder dissection.
Something important is that it's different when you crack the capsule before doing the bladder flap, or maybe this case, I think the cracking was above the dissection level, yes? So it's not so heavy bleeding.
Alvaro,
present.
talk about your experience with the use of to use in this structure.
I think Dr. Jose is talking about clamp, vascular clamp. If you have a big crack, you can put a traumatic vascular clamp, Satinsky or any other vascular clamp. You can use it, but you will need to have space to put it because you need to put the angle. So it's not easy. The ideal situation is don't crack in the capsule, please.
Yes, but I have an experience with this vascular clamps. The problem is you can put it correctly, you can stop the bleeding, but because this clamp is taking space, sometimes people inside, the assistants and the nurse and stuff like that, when trying to help you, okay, sometimes they just push this clamp and then you find it outside the cracked capsule. So I'm trying to do something that is atraumatic for all of the patients, because sometimes when you have this clamp inside the field, sometimes the assistance, if you just touch this clamp, the capsule crack more. So it's good, but when you talk it in real life, in a large volume of cases, if you do it, sometimes it may be a little bit hazardous. So when you lose a hand out of 6 hands in the field, and you have 5 hands in the field, and then the mindset of the one who put the gauze and do the compression is that you must understand this, he must put in his mind that whatever, anything will happen, you will not ever remove this gauze. You don't work in this placenta anymore, you just do compression. This is very important till we do the proper bladder dissection.
Any luck with stitches? Large bore stitches? Any luck?
Sorry?
Stitches in the cracking. Stitches.
Any luck with
in the...
stitches?
No, if you put stitch, you crack more because it's very thin. If you insert the needle,
It's bigger.
it becomes bigger.
Bigger.
Ahmed, thank you so much. I think we have 1 hour and we promise to keep on time. So if you agree, maybe we can end. I think you are ready to do the closure remarks, or you want to say something else?
No, it's for you, Alvaro, now.
No. We hoped to extra session maybe. And again, please join us. It's not difficult. People in the United States are reaching YALDA, and OSAN are reaching the IRB. People in Europe, that is also difficult. They are reaching the ethics approval. And we really need your help. That is the only way to build this high quality evidence. If you have low number, your information is useful because your situation is totally different from hospital with high numbers. And we will solve not only the question about the classification. As Ahmed said, we will explore a little about education, about the usability of this, about the difficulties we have. So you are more than welcome. Just send us a message, a WhatsApp, a message, an email, and thank you again for being connected today.